Hi everyone. I'm Natan Franck, if anyone doesn't know me, and I'm gonna give a lecture on
by now.
yeah, well, I don't know, maybe there's new interns or I don't know, someone listening. But so I'm gonna give my lecture on small things we can do, kind of do better that are seemingly small and insignificant, but can improve our clinical practice and provide better care to our patients in the end. And it's not meant to be the end all be all on these topics, and it's kind of a random smattering on topics, but it's just to get you thinking and questioning what we do. And that's one thing this residency has taught me to do from many of our faculty, to like really ask what we're doing the best thing for our patients? Is what we're doing necessary? Can we improve what we're doing? And hopefully I picked some topics that we haven't talked about to death. Like, so I've tried to avoid like things like C-collars and trauma and backboards and trauma. So they're a little bit more random and esoteric, but hopefully it'll get us thinking. So the first one is talking about difficult intubations. So how many of us had seemingly normal looking patients with a normal appearing external exam without any confounding risk factors for being a difficult airway turn out to be very difficult. So yeah, all of us, I'm sure. So, I mean, what approaches do we use to like assess for a difficult airway? Sometimes we don't have enough time to do anything, right? And we just have to prepare for the worst, and just having everything ready is important. But if we do have time, many of us jump to Melon-Potty, probably the most well-known score. It's in like the procedural sedation paperwork, so we are supposed to assess it. And it's probably the first thing we'd think of. Once we develop some senioritis, most of us don't really do anything, and we just look at the the anatomy of the patient and look for like things like trauma or something obvious, and we kind of make our decision on whether or not it should be a junior or senior airway. So what kind of data do we have? The Cochrane group did a pretty big meta-analysis on 133 studies of 844,000 patients. These are almost all operating room studies, so 131 of 133 were in the operating room. So they might not be as generalized with TED, but I think they're still helpful. So they looked at our scoring systems, and what really matters in terms of a scoring system in a difficult airway would be really high sensitivity or high positive predictive value, because this is a screening test. So under each one, I have the sensitivities from the review. So thyromental, sternal mental distance was 37 and 33% sensitive for a difficult laryngoscopy. They were 89 and 92% specific, but again, we want higher sensitivity at expense of specificity in this. For Melon-Potty, the actual Melon-Potty we look at is actually the modified Melon-Potty, but the original Melon-Potty had 2 and 3 combined as one group. So modified Melon-Potty was 53% sensitive and 80% specific, so still not very good. Mouth opening test, so you look at the width of mouth opening, that was 22% sensitive, 94% specific, and then a complicated Wilson risk score, which is based on like weight, neck movement, and a bunch of other factors, was also pretty poor at 51% sensitive. So what's the best single test for looking at an airway? It was actually upper lip bite test, which someone has already demonstrated in the crowd. But I didn't know about this test before I heard about this. So what you do, it kind of assesses for the movement of the lower jaw, and you divide people into class 1 through 3. And if the patient can bite their lower lip, including the vermilion border, then they're class 1. Class 2 is if they can bite any other lip, and class 3 is if they can't bite their upper lip. And the differentiation, at least in the Cochrane review, was class 1 and 2 for being easy, and 3 being a difficult or possibly a poor intubation. And for difficult laryngoscopy, this was 67% sensitive and 92% specific. So still not very good, but of all the tests, this was by far the best for different laryngoscopy and pretty easy to do. Maybe even easier to do a Melon-Potty score. Yeah, true. And again, a lot of our intubations are very emergent, and we don't have time, or the patient is unable to do this. But if we have time, or we're looking at, if we're doing procedural sedation, if they can't do this movement, maybe we should be considering if procedural sedation is safe, in these patients. So my next topic, totally going on a different tangent, is squamous cells in my UA. So we're traditionally taught that squamous cells are found in the distal urethra and the vulvovaginal region in patients. And what do our textbooks say about squamous cells? So Tintinales writes that if the sample is properly collected, it shouldn't contain epithelial cells, or just few of them. And then Rosens goes even farther and says, pretty much implies that if squamous cells are present, it's not acceptable for analysis. None of them really say what to do or how to interpret UAs in the setting of squamous cells. But if you look at what Rosens is saying, they're pretty much saying it's an invalid sample and you should repeat it. So is this true? We have a couple studies. So this first one is a prospective study of 105 women who presented ED with symptoms suggestive of UTI. They both were cathed and then had a midstream UA collected. Interestingly, 94% of the cast specimens had at least 1 to 9 squamous cells, and 18% of the cast specimens had 10 to 29 squamous cells. 96% of the midstream ones had at least 1 to 9 epithelial cells, and a pretty high number of the midstream samples had 10 to 29 epithelial cells at 39%. So interestingly, none of the cast samples had any bacterial contamination, even though 18% of them had over 10 epithelial cells, and 21% of the clean cast samples did have bacterial contamination, but still pretty low number. And they pretty much concluded that you should not assume a urine sample is contaminated or the results of the, especially the culture, are invalid just because of the presence of squamous cells. So a bigger study, this is a retrospective review of 19,000 patients who had UA and urine culture performed in the ED. And they found that squamous cells did not predict contamination. So they didn't find a correlation or association between presence of squamous cells and bacterial contamination. They couldn't find even a cutoff value of epithelial cells where bacterial contamination was really highly likely. And that they found that nitrites were unaffected by the presence of epithelial cells. They did find that if you have greater than 8 epithelial cells and you're making your diagnosis of a UTI based only on pyuria, so leukocytes and white blood cell counts, that it hurt your likelihood ratio for diagnosis of UTI. So if you had less than 8 squamous cells, then your likelihood ratio for UTI with pyuria was 5. But if you had greater than 5 squamous cells, then it came down to 2.35. So they proposed, and what I kind of agree with this, is if you do counter squamous or epithelial cells in your UA, and you're concerned for a UTI, presence of nitrites should allow you to just treat for a UTI and you don't have to repeat the UA. Negative UA with epithelial cells is still negative UA and you don't have to repeat it. And then if you're basing the diagnosis of a UTI only on the presence of leukocytes or white blood cell counts, and you have greater than 8 epithelial cells, then you can consider repeating that UA, and that you shouldn't invalidate culture results just based on epithelial cells themselves. Next topic, ouch, my finger. So we get a lot of finger injuries, and we've been historically taught to never use lidoid epi in digital nerve blocks. I've never actually used lidoid epi in any digital nerve blocks because I've been so scared of doing it, and I've been taught by my attendings not to do it. So why do we care? We use lidoid epi on almost all other like lacerations because it really helps, right? It allows the anesthesia to last a lot longer. It gives us a much cleaner feel with the vasoconstriction, and it allows us to safely give a much higher dose of lidocaine to our patients without giving them toxicity. So what do Roberts and Hedges say about this? And Tintinales? So Roberts and Hedges gives kind of like a hedging recommendations where they say that several authors have suggested that Lido with epi can be safely injected in the finger without adverse sequelae, but they don't really give a strong recommendation for it. And then Tintinelli's writes that traditional teaching says that it's risky to do, but that there's recent literature saying that it's not. So why did we even come up with this conception that Lido with epi is dangerous? It's based on 50 case reports from 1889 to 1948, where there was finger necrosis or gangrene after digital block. Interestingly, only 21 of these 50 cases even had epinephrine used in them. And then a thorough review of all these cases have found more plausible cases of necrosis and gangrene. So either severe concurrent infection, there was a tradition of dipping fingers or extremities into hot soaks, boiling water, caustic agents, prolonged tourniquet use. And before the 1950s, there wasn't a commercially available formulation of lidocaine with epinephrine, so people would just mix their own, and the concentrations varied significantly and were much higher than what we use right now. And also the anesthetic agents used at the time were often different, like cocaine was highly used for this. So do we have any data that's safe? Well, we have 2,800 cases of digital nerve blocks with epinephrine in retrospective and prospective studies done in healthy patients, and they all had no complications. And we have no cases of gangrene or necrosis attributed to epinephrine. And there's been no case reports of digital necrosis or gangrene associated with Lido with epinephrine since 1948, when the commercial formulation of lidocaine with epinephrine became available, which was much safer. Do we have any other evidence? We do. EpiPens, as we know, have a very high concentration of epinephrine, so 1 to 10,000 versus the 1 in 100,000 we see in Lido with epi. And this is a big retrospective cohort study based on 6 years of poison control center cases in Texas. They had 365 injections of EpiPens to the hand, 213 were digital, 127 were followed up on. So we keep losing ones, but it's okay. All these patients had complete resolution of their symptoms in the emergency department. 23% received vasodilatory treatment, so like phentylamine or topical nitroglycerin. And 3.1% had reported ischemic fingers, but they all had complete resolution of these symptoms in the emergency room and were discharged home, and none had to be hospitalized or received any surgical care for it. The one big caveat with all of this is that almost all these studies and these case reports and these case series were done in healthy patients. So there are a lot of the guidelines now state that it's safe to do, but we don't have great data in patients with comorbidities or vascular disease. We don't have strong evidence it's dangerous, but the evidence for safety is decreased. So if we're gonna start doing this, we should probably hold off and at least study whether or not it's safe to do in people with like hypertension or severe hypertension or peripheral vascular disease or diabetes. So next topic, was the cremosteric reflex present? So how often do we call our consultants for emergent diagnosis that we're worried about, and we get asked certain questions, and we wonder how important are these questions to answer, and do they matter for the diagnosis of the condition? So what do our textbooks have to say about this and up to date? No one really gives numbers, but Tintinelli states that cremosteric reflex is a sensitive finding in testicular torsions, and you should look for its unilateral presence. Rosen says that it's usually absent in patients with torsion, and up to date says a negative testicular cremosteric reflex is associated with testicular torsion. So what does the data say? We don't have, so we don't have great data on this, but in studying just healthy people, healthy children, a lot of people don't have cremosteric reflexes. So this is a study of 500 children through a variety of age groups, and about 30% of the children don't even have the cremosteric reflex. And even in some, there's some laterality. So they'll have it on one side, but not have it on the other side. How about in patients with torsion? We don't have any big big studies, but we have a lot of case series or case reports. This is one of the larger ones of 25 cases of surgically confirmed torsion. And in these cases, 40% of the patients had an intact premotoric reflex. And the rate of intact premotoric reflex in torsion is 80 to 40% in most of these studies. So effectively, this is gambling, right? I love craps, and you might as well just gamble in terms of whether or not the premotoric reflex is present, because if it's missing in 40% or 30% of people at baseline, and it's present in 40%, it's not really going to help you make or break the diagnosis of torsion at all. Next topic, how many times have been asked for tramadol, or been told, or been given, or have given patients tramadol thinking it was a safe medication, that it was not going to cause harm to our patients, and kind of when we're at the end of our ropes and we want to give something, a lot of people would go to this medication. What do our textbooks say about tramadol? So Tintinelli's reports that the tramadol opiate effects can vary widely, and don't give it a strong recommendation, but don't strongly discourage its use. Rosen's kind of gives us a favorable look on tramadol, and it says that it has a favorable side effect profile, and that it has a lower risk of addiction with chronic use. And these are all the most recent editions of our textbooks. So this is one of our favorite molecules, cytochrome P450. So tramadol itself is not an active opiate, and it must be metabolized by P450. Interestingly, 3 to 10% of patients or the general population don't have the necessary enzymatic activity to metabolize tramadol into the active metabolite, so they get no analgesia from it. And then a small but significant subset of people are ultra metabolizers and have really high enzymatic activity, and will get a lot of opiate effect of it. This drug also acts as an SNRI to make it even more confusing to use. So does it work? It doesn't really work that well for analgesia. There's a lot of studies that show that it's equivalent to ibuprofen for a variety of indications, and that it's not really superior to ibuprofen or Tylenol on its own. And it's also pretty unsafe in certain situations. So ultra-metabolizers are really high risk of complications, and we don't know who these ultra-metabolizers are. So this is a case report in pediatrics. It's a 5-year-old boy who went home after tonsillectomy. They were sent home with tramadol for pain. They got 1 mg per kg of tramadol, and the normal dose is 1 to 2 mg per kg for postoperative pain. They got it at 11 p.m. The next morning, they were found by their parents to be lethargic. They were brought to the emergency room. They had a GCS of 8. They had minimal respiratory effort. They had episodes of apnea. Their initial O2 sat was 48%. They ended up doing well with naloxone and non-invasive ventilation, but this could have obviously gone a lot worse and could have been a really disastrous outcome from a low dose of tramadol in a patient who didn't have any known medical problems. Later analysis found that they were ultra-metabolizer, but this was only figured out after the fact. Tramadol is also associated with seizures, especially in overdose. It's also possibly associated with Alzheimer's and Parkinson's disease and long-term chronic use. It has a 3-fold increase in hypoglycemia compared to other opiates. And this is just a graph of it versus tramadol, or versus codeine in patients. And it shows that the risk of hypoglycemia just goes up with longer use. And then it's even associated with all-cause mortality compared to other analgesics, especially NSAIDs. And then finally, this is a large retrospective study on 500,000 Medicare claims for patients receiving opiate-naive patients receiving opiates from 2009 to 2018. And they found that the tramadol group was either just as likely to become addicted or start using opiates long-term, or more likely to start using it. And they actually had a 7% increased adjusted risk of persistent opiate use compared to most other opiates. And what schedule is tramadol? Schedule 4. which means it's low potential for abuse and dependency as per the DEA. So we often think of it as a safe, potentially less addictive medication, but it really isn't, and we really shouldn't be using it. So the last topic is, did you do orthostatic vital signs? So how often have you tried to admit someone or ob someone for cardiogenic syncope and been asked if they did orthostatic vital signs? Does it matter? Should we be doing orthostatic vital signs? So what do the guidelines state? So in 2007, the 2017 consensus guidelines from the American Heart Association for patients with syncope recommend strongly doing a proper history and physical, which I agree with, of course, but also documenting and looking at orthostatic vital signs. And then they have a whole algorithm for what to do if the patient has orthostatic vital signs. So what do we know about orthostatics? Well, this is a study of 911 patients who were in nursing homes, who were not sick or hospitalized and just had vital signs taken. They measured blood pressure throughout the course of the day 4 times, both sitting in an orthostatic. And then 51% of these patients were technically orthostatic by blood pressure, at least once during the day. 19% felt dizzy on standing, and there was some correlation with orthostatic hypertension, but it wasn't strong. This is another study that showed that even young children who are healthy can be orthostatic. So they had, this is a little bit artificial, but they had 23 adolescents aged 13 to 19, and they did a tilt table test, and 44% had orthostatic hypertension. There were some limitations in the study, its artificial nature, and the fact that it didn't wait a full 1 minute to take the blood pressure, but it still showed that we can get blood pressure decreases in healthy patients, and it doesn't really mean anything in particular. So do we have any reviews or any data on this? Well, Dr. Sinnert wrote a wonderful brief review paper in 2005, I believe, or no, 2004, sorry. And he found that after in phlebotomy studies, so with moderate blood loss, like 450 to 630 cc's, orthostatic hypertension had a whopping sensitivity of 9% in younger patients and 27% in elderly patients. So really poor sensitivity for pretty significant blood loss. And then in larger volume blood loss, so 630 cc's to 1150, he did find that orthostatic pulse rate increase was highly sensitive and specific, but that even orthostatic, or the perception of orthostasis, so mild postural dizziness, was poorly sensitive. But they did find that severe dizziness, so inability to stand to obtain orthostatic vital signs, was highly specific for hypovolemia, but otherwise very useless. This was echoed in an earlier JAMA Rational Clinical Exam series, which also found that postural hypertension was really insensitive for moderate blood loss, and that postural hypotension was only 29% sensitive for hypovolemia from dehydration, and that they pretty much concluded that the most helpful finding for suspected blood loss or severe hypovolemia was inability to stand and severe postural dizziness, and that it was highly specific for hypovolemia and blood loss, but it was not very sensitive. So 98% specific, but 22% sensitive. And they also found that mild postural dizziness or lightheadedness on standing had no proven value for diagnosis of hypovolemia or blood loss. So what does this mean for us? We should look for symptoms of severe orthostasis. So if someone can't participate with orthostatic vital signs, obviously something is wrong. But in the end, we should obtain labs when we're clinically suspecting significant or suspecting hypovolemia or blood loss. And then we can't make this diagnosis on orthostatic vital signs or even the perception of orthostasis. So I just wanted to thank everyone, the faculty especially, who've kind of made me like want to think about these kind of topics and lecture on them. A lot of what we do in this residency is kind of ask ourselves what we do and is this right? And this isn't supposed to be the end all be all on these topics, but it's supposed to get you start thinking. When you're asked by a consultant, if you did something, why are they asking this question? Does it matter? And are we going to falsely assume that someone doesn't have a surgical diagnosis based on a physical exam finding? Or are we going to falsely think that they didn't have cardiogenic syncope because they're technically orthostatic by vital signs, or they perceive orthostasis? We really have to think about what we do, and we don't want to falsely be pushed down a rabbit hole of treating something that's not there or treating the wrong thing. We've been through a lot, especially when CCT board looked like this. Obviously I would never want to go through this again, but going through COVID and everything we went through with everyone in the residency, I couldn't have asked for a better group of people. And we, even during the worst of it, like the top over their bad CCT shift, people were still in good spirits and worked together. And Ronnie, the haircuts, thank you. And finally, I want to thank you to our class, including the EMIMs. One of the best classes, obviously, and I couldn't have asked for a better experience in residency. And these are my references. Any questions?